So I know a few of those in the room, and I have the feeling that there's a few around who are concerned about a baby with a child, a grown-up with hypoplastic left heart syndromes. Do you want to raise the hands, those with a hypoplastic left heart syndrome? So it's usually a higher proportion, thank you very much, because it is the condition that is offered a Fontan operation that is considered the most severe of the condition. And it's because you're missing the left ventricle, so the main pumping heart chambers that propels the blood into the entire body. Let's see what we know. So we have this output from the Fontan Registry, the biggest American journal, and we put that title, Redefining Expectation at the Fontan Procedure. Everybody else has done that for 40 years, but we redefined the problem, which I thought was very presumptuous, but exactly as David Selemaya told this morning, that's what we did. The people are now seeing the Fontan in a more optimistic way than before that paper. And so you've seen that graph, that's the growth of the Fontan population. And I'll quickly take the opportunity to give the expectation of survival for the entire population, because we have the longest follow-up at this stage, and we still have to work on this before it's going to be soon published in your annual review. But we have now 30 years expectations for the atrial pulmonary Fontan, which is above 60% of survival, which may not be looking very good for you, but that's way better than anybody would have expected. And it is 87% at 25 years for lateral tunnel, 93% at 18 years for extracardiac conduit. What we get from this data is, one, the results are better than the people expected. And two, there is not, as the people expected, a sudden drop after a certain stage where it's deemed not to be working after a certain stage. Things are going on. We don't see any sudden deterioration at any stage. And yes, hypoplastic left heart syndrome, it's a little bit worse than having another condition, but not a lot worse. So there's no difference at this stage in survival. At 30 years, we still do not see a difference in survival. The biggest center in the world to have outcomes for patients with hypoplastic left heart syndrome is Philadelphia, because Norwood, who designed the first operation for hypoplastic left heart, was from Philadelphia, and it has been a magnet in the United States for all the patients with hypoplastic left heart syndromes. And so they've just presented, it's not published yet, the series of Fontan, and half of them had a hypoplastic left heart, half did not have hypoplastic left heart. No difference in survival at this stage. But still, if you look at our experience, if you look at all adverse events, so reoperation, transplantation, not only death, but if you look at strokes and all these things, there are differences. But the differences are not enormous. So at 10 years, there's a difference as close to a bit more than 10%, but it's not enormous. And when AJ did this analysis, we saw it's not so much that you having a single right pumping heart chambers, as the muscles that push the blood, is worse than having a single left ventricle. The problem is that when you have hypoplastic left heart syndromes, you often have other issues. Your valve is leaking, your arch, the aorta, the pipe that comes out of the heart is a bit kinked, there's something. The lung arteries have not grown harmoniously. So it's not so much the muscle in itself. What can you do? Well, if you want to have good results, I was asked that question for the Conference of Australia and New Zealand. Well, the best is to start with good patients. And so we know that there's a lot of factors that will make your life miserable or will have you having very poor results, generally speaking, early after birth. And we know them, low birth weight, tricuspid regurgitation, poor function of the heart, other anomalies in the heart or outside the heart, and the baby who arrive in bad conditions, then we know that we're going to have bad results. And that's why you should have the delivery for these complex conditions close to the hospital where you're going to have your care and having a diagnosis before birth. The things that are bad is massively leaking valve or really poorly functioning heart. You should not take that because you're going to have bad results. Leaky valve, so the valve between the pumping chamber and between the collecting chamber is the tricuspid valve in hypoplastic left heart. And tricuspid valve regurgitation has been a big issue, and in the North American series, about a third of them would have that. We've done some work in Melbourne because we tend to put very small shunts at the first operation in Melbourne, and that seems to be of benefit. If you have a smaller shunt, we've shown, and you've seen, I was surprised that Ben managed to have you laughing about odd ratio. I mean, that's the first guy I ever see making you laugh about odd ratio. But if you have a bigger shunt, you had a higher risk of having a tricuspid regurgitation. And if you put a small shunt, we had 7% of those developing tricuspid regurgitation, 40%, close to half, if we put bigger shunts. And yes, the heart was bigger if you put bigger shunts. And I think that's due to something that we evidenced a few years ago, is that, you know, in the heart muscles, you have cells. These are the stuff that, you know, are pulling stuff against each other. And it's embedded in the extracellular matrix. It's the structure that support the cells. And in hypoplastic left heart, we think that there's more cells and less matrix. And that's maybe why, you know, these babies, if you put a bit of too much blood into the heart early at birth, they tend to stretch out and the valves start to leak. If you want to do something, you have to have good arches, so the pipe coming out of the heart, and you have to have good pulmonary arteries. And I show that picture. That's a patient where I did a BCPS, so the stage number 2. There was barely a little tiny kink here, and that was enough for me to say, okay, I'll reoperate. We don't even look at, normally we have criteria of obstruction. Nowadays, we think that we should be quite aggressive on aortic arches. And when we look at the results of the Fontan registry, having an arch operation at Fontan or before Fontan expose the people of higher risk of all adverse events. So having also not only death, transplantation, but, you know, a stroke, irregular rhythm, anything that needs a hospital stay. So arches are likely important. Pulmonary arteries are also important. So these are the size of the pulmonary at the time of the second operation and at the time of the Fontan. And here are the big pulmonary arteries, here are the small pulmonary arteries. And you can see that graph tells you that if you have small pulmonary arteries early in life, you keep your small pulmonary arteries. And there's no doubt that you will exercise better, you have a better and a longer life if you have bigger pulmonary arteries. So in hypoplastic left heart syndrome, something that is seen very often, and we're not very clear why is that. Some people, there's not enough space because of the funny arch and the operation. Maybe it's the flow distribution. We don't know exactly, but they tend to have smaller left pulmonary artery. And so we've started doing something. In that patient, we did a shunt. We added an extra operation to push the blood into the left pulmonary artery and to grow it. And so far, we've been happy with the results. We've done about 15 of them. So there may be strategies that we can do to get better pulmonary arteries. And if there are anything you can do, you should try. And I think, in my mind, sometimes I think that, you know, we should put maybe small shunts at the first operation and then add up an extra operation. If we find that the pulmonary artery has been on a small side, it may, you know, be worth just wait and push more blood into these lung arteries. So you see that a lot of the things are the things you can do before the Fontan. Well, you've done the Fontan and you have a hypoplastic left heart, there's one thing you can do. And about the thing that is the most efficient to be better after a Fontan with a hypoplastic left heart is exercise. And so David talked about the work that he did with Rachel, and we're going to talk a lot about that, but that's the most efficient way to increase your exercise capacity. In 8 weeks, and 8 weeks only, which is remarkable, you increase the amount of blood pumped by the heart by 10%, the exercise capacity by 10%, objective signs of circulating blood in your body and, you know, delivery of oxygen to your body by 15%. And Nigel has done a work now with a home exercise program that we'll present you in this afternoon. Medications, well, it would be nice to know what to take. I don't know about who's on medication, you know, not counting aspirin or warfarin, which everybody has likely. Who's on medication? Who's on no medication apart from aspirin and warfarin? Okay, still a few. Well, you may have good reasons to have a lot of the medications you're taking, but the chances are, and Julian alluded to that, and we've quoted the work of Thomas, is that the chances are is that in very good faith, your doctor thinks that it's going to be better for your long-term future, but we actually have no idea. So it would be nice to know if we have medications out there that will make you better, will increase your exercise capacity, and will give you a longer life. But it's likely that apart from aspirin and warfarin, and if you don't have a good reason to have a medication, so if you have a leaky valve, you should take your medications. If your heart is not pumping well, then you should take medication. So there are indications. But if you have no indication and you're doing well, it's not very certain that your medication will help you. And then we've mentioned that abundantly this morning, you should make sure that you see your doctors. And I think that we see now already the benefit of the registry, and the things were different before we started the registry. But today, the people who are in regular contact with the registry, 80% of them are seeing doctors regularly. I had seen a doctor at least in the last 2 years. And that is remarkable if you look at congenital heart disease, the best results usually is 50%. So we are achieving something with the registry already. So that's all you have to do. Thank you very much.